And for that particular session, I would like to invite speaker Dr. Abhay Kumar, who is a urologist, and he would be speaking on male lower urinary tract symptoms, a complex web. And for that particular session, I would like to invite Dr. Rajesh Lunia as the chairperson, who is a urologist attached to Narayana Hospitals. And I would also request Chairperson Sir to introduce our speaker for the next session. You speaker, sir, for all of us.
It's my pleasure to introduce Dr. Abhay Kumar, who is well known in Havra as a speaker of today's session. Topic is male LUTs, a complex web. Dr. Kumar, please continue.
Thank you, Dana sir. I think I'm not against it. My own people and maybe only resident urologist in Havra. All the urologists who reside in Havra. Okay. And so I'll be talking about LUTs, which may not be my preferred topic, but this was what was asked me to do. Anyway, I'll try to make it interesting one. So, lower urinary tract symptoms is the term that we coined, and many ask me, why, what is lower, what is upper? So, urinary tract is basically the kidney, ureter, bladder, prostate, urethra, and we divide, for our convenience, the kidney and the ureter as the upper tract, the prostate, the bladder, the urethra as the lower tract. And the symptoms that we feel are arising from this lower tract, the so-called bladder, prostate, urethra, are termed as lower urinary tract symptoms. So, act of micturition is a complex activity, and it's got a lot of universal controls. So, I gathered from the last session, last talk, something about neurology and part of safety. So there is a lot of controls which are central and peripheral, and so like in a computer, there is software and there is hardware. So the hardware are the anatomical organs like the kidney, prostate, bladder, and this neurological complex there is the software which drives. And if there is any abnormality in any of the software or the hardware, this act of holding the urine or passing the urine is going to be a challenge for the person. So LUTs can be because of various reasons. So earlier we thought that prostate problem, prostatism, urinary symptoms are synonymous, they are same and related to prostate is the only source of this. But no, it's not like that. There are various reasons, various causes which can have similar symptoms, similar presentations, similar manifestations. And that's why here thorough evaluation, examination is very important before prescribing a drug which are elements how to use it. So that's can be because of obstruction, like benign obstruction prostate, any foreign body, any stones, any strictures. Because of any infections, like infection prostatitis, because of any bladder pathology, bladder can be either normally active, overactive, or underactive. So basically, bladder has got two functions. One is to store urine, and when the blood is not able to store urine for a long time, the storage problem, that means blood is more active or overactive. And when the bladder needs to push past the urine, it's not able to push, that we call blood is underactive. There can be some malignancy like bladder problem, bladder tumors, prostate cancers, or can be the cystomas. So this is the problem, like upper tract problem, like the ureter problem manifests as the lower tract symptoms. The stone is there in the ureter, presents like there is some problem in the lower tract. Patients complain of frequency, urgency, dysuria, and pain. Then the systemic causes, diabetes is very important, can have symptoms which we think can be as lower tract symptoms, but actually prostate is not a problem, lower tract is not a problem. The problem is the diabetes. So this is normal prostate, and when prostate is enlarged, causes obstruction in the outlet. But is that so simple? No, actually, even if prostate is enlarged or there is anatomical enlarged prostate, it may not cause symptoms. And when there is severe symptoms, prostate may not be enlarged. So it's a complex web of things which all together taken into account we diagnose whether this patient is having LUTs purely or LUTs with BPH, LUTs without BPH, or there is some problem in the bladder and the prostate and LUTs are not there. So again, enlarged prostate causes obstruction. Is it true? So any person which is more than 40 years of age, prostate is going to enlarge because of hormonal changes in the body. Like females have menopause, the males have andropause. It's not so common, well-known entity as andropause, but it happens. Hormonal changes also occur in the males and they have some manifestations. And one of them is enlargement of the prostate. But all the enlarged prostates don't cause obstruction. So enlarged prostate can cause bladder outlet obstructions, but not all the enlarged prostates. There can be some secondary changes in the bladder because of the enlarged prostate, and bladder may become very sensitive. That's termed as overactive bladder. But prostate may be normal in those cases. So clinical enlargement, symptomatic symptoms of prostate, and some changes all combined can have symptoms. So if you are a male, for a man, and you are going to survive longer, prostate is going to enlarge, and as the age increases, the severity increases. But this is interesting. Of all the patients with enlarged prostates, just 50% will have symptoms. The rest 100% don't have any symptoms. So if you get an ultrasound report and it's routinely done and you see zoologist has given enlarged prostate, that doesn't mean this person requires treatment or intervention. You can ask, do you have any symptoms? And then we will. So surprisingly, 50% don't have symptoms. And of those 50%, those who have symptoms, around 90% can be treated by medicines alone, pharmacotherapy. Thanks to because of Urimax, it's common. Everyone knows what is Urimax and household name in people having elderly population. So across the board, Urimax, Urimax. So 90% cure by medicines, and just 10% or 1 of 10 will require surgery. So there is a huge role of general practitioners, general physicians, or palliative physicians who can manage this problem. But all the prostates are not similar. All the enlarged prostates are not the same. They behave differently. Some may remain static or respond to treatment. Some may progress. So it's very important to know which subset of patients are going to progress over time and require surgery in future. Because timely surgery makes a difference. Before the bladder gets damaged permanently or becomes weak, before the kidneys start getting damaged, timely intervention or surgical intervention is very important. That's why whenever you prescribe medicines or Urimax, follow the patient, whether he's improving symptomatically, whether his parameters take ultrasound, are getting any better or not. If not, then send or refer for surgical management. Complications of BPH, most commonly retention of urine. Sometimes patients feel that I'm having pain and I'm not able to pass it. Sometimes they don't feel. That's called painless retention of urine, and that's more worrisome. Recurrent UTIs, sometimes patient becomes a barbaric position. Diabetic patients, more UTIs, but you find prostate or maybe blood is the one which is going to be. It can cause bladder stones, kidney failure, and decompensated bladder is the most worrisome because there is no cure for that. Once the bladder becomes flabby or weak or decompensated, there is no treatment. The patient will remain on catheter for maybe the rest of his life. So before that, counsel, treat, and follow the patient and send for surgical intervention. Hematuria is worrisome, bleeding, blood clot, and just if anyone passes a drop of blood, they are frightened, they are afraid. And if the catheter, the uterus gets blocked, get clot retention, that's again emergency. Factors which increase the risk of BPH, dyslipidemia and diabetes is one. Hypertension, so these are called metabolic syndrome, and there is a lot of research now going on regarding the metabolic syndrome and the incidence of BPH and how it changes the course of BPH. Okay, so I think that was so symptoms, yes, we have already discussed. symptoms, like when we are students, we used to study like bladder symptoms are divided into obstructive type and voiding type and the storage type. Similarly, as I said, the bladder has got these two functions. One is to store urine. Whenever there is any difficulty in storing, the symptoms are labeled as storage symptoms, like frequency, urgency, and nocturnal. So if the person has to get up in the night to pass urine, even once, it's nocturnal. अगर 10 बजे सोया, सुबह 5 बजे उठ गया, in between he's having peaceful sleep, it's not nocturnal. But if he gets up in 1 o'clock or 2 o'clock, and then again goes to bed, then it's nocturnal, and that's the problem. And people don't appreciate it. So after एक बार घूमे उठे किंतु हमें ठीक है, but we don't know. So if person is not sleeping well, his next day is not good, is not productive, he is feeling sleepy next day. Urgency. So whenever the patient gets the urge to pass urine, normally people can hold for some time. Like if they are sitting in this hall and everything is pretty. But if you are getting such a urge that you can't hold and you rush to toilet, that's urgency. And sometimes there is urge incontinence as well. That before there is a toilet, one or few drops leaks in the toilet. And frequency is any increase. I mean, you can't give any numbers like more than 6 times per day or more than 8 times per day is frequency. Any change in the lifestyle of the person. Like if the person used to go 5 times per day, now he has to go 6 or 7 times, and it bothers his life, then that's the problem. That's the increased frequency. What are the symptoms? So these are the storage problems. Patient is not now the voiding symptom. Now the patient has reached the toilet, but he is finding it very difficult to start the act of urination, that is very agency. Then when he starts the act of urination, the flow is not that good. Overflow, and then he has to push or strain to pass urine, like the straining. And after this, he doesn't feel satisfied. So this is sense of incomplete evacuation. So these are the symptoms which are there when the patient is trying to pass urine, and they are labeled as voiding symptoms. So these are symptoms, and this is because of prostate enlargement. Metabolic syndrome we discussed. LUTs and urolithiasis, yes, stones can cause similar symptoms. Overactive bladder I discussed, and BPH we have discussed. Okay. So LUTs in metabolic syndrome is high, around 50%. So diabetic patients will have LUTs 50%. I mean, so whenever you see a diabetes patient, you have a urologist. So correlation of LUTs and urolithiasis, yes, stone formers will have more chances of overactive bladder. So BPH patients, Urimax is the one, or maybe to relieve the obstruction. But if the patient has got severe storage symptoms like frequency, urgency, nocturia, that means the bladder is also has some changes, and you need to take care of the bladder as well. So there are some medicines available, so you can prescribe those combinations of alpha blockers to relieve the obstruction in the prostate and to relax the bladder. You need some other antimuscarinic or vitamin A agonists, which are available in market. Differential diagnosis, questionnaire, so all the patients of BPH don't require medicines. Some may be kept on watchful waiting, as I described. So if ultrasound report says in large prostates, ask for symptoms. If no symptoms, can be just follow, no treatment required. Sometimes self-management like lifestyle changes. The patient is having more fluids in the evening, ask them to because it will jolt compound so that you have a good sleep. And if he is indulging in too much of fluids, like basically jolt high, so ask him to moderate amount of fluid and ask to decrease the diuretics, tea, coffee, spices, and alcohol. There are lifestyle changes. Sometimes constipation adds on these LUTs, so if the patient is constipated, treat the constipation as well, so they have a better quality of life. Medical therapy is most commonly used in the patient's mild or moderate symptoms, and surgical therapy is the last resort. These are the guidelines. So PSA, so Enlargement of prostate can be benign or malignant. And if you are seeing a patient and thinking that he's got a prostate, enlarged prostate, please get a PSA done, because he may be having a prostate cancer as well, and prostate cancer is not that uncommon. Prostate cancer is a very common problem, and if diagnosed early, can be cured. So PSA is, I kept this slide blank because there are a lot of questions on PSA, so I kept it last. Please examine the patient, because many times we have seen this. Diabetic patients particularly have this problem, fibrosis, and many times we diagnose diabetes in retrograde. Patient comes with this problem. It's a diabetes है क्या? He is not aware. ना सर आपको diabetes नहीं. Sugar check कराओ, it comes out. So retrograde diagnosis of diabetes, in particular young, we have gone through and seen, looking at this penis. So please examine the genitalia of the patient will come with symptoms of that. It may be just a fibrosis and not a prostate. And on retrospective, you can find out it's diabetes also. Examining the bladder is very useful, because many times patients comes and tells, sir, our bar picha hoche. Very frequent time passing urine rate leak hoche. But when you palpate the bladder, you see that actually it's what the person is telling you is the overflow incontinence. The tank is full and getting overflowed every hour. So unless you examine the patient, you will not be able to find. Later on, you will see an ultrasound that is post-viral residue is more than 500 over the 60. In diabetics, more UTIs, more bladder issues, and sexual dysfunction. Sexual dysfunction can be both males and females, and I think that's a very big topic and beyond the scope of this meeting. Yeah, bladder dysfunction. Okay, so bladder cystopathy was a term coined for the patients of diabetic who had bladder problems. Like because of neuropathy, the bladder becomes insensate, bladder becomes large, bladder is not able to push urine. So, but what we have seen is that that's the less common presentation, and that's the last basic presentation. More common presentation is patients coming with storage symptoms, like the frequency, urgency, nocturia, and nocturia. So this bladder dysfunction is more common than bladder cystopathy in diabetic patients. One more common thing being surgeon, that is, doc is not completely the surgical things. So what I feel is more important nowadays in diabetic patients or any patients coming with the kidney problem is the kidney tumors. So incidentally diagnosed renal masses are very common, and around 5.5 around 4% of the tumors are diagnosed incidentally. Patients come with some similar problem, you got a routine ultrasound done, and then we find a complex cyst or small tumor. Now, because we have a large diabetes population, diabetes capital and these masses are getting very commonly now, and CKD is also common, because as diabetes happens, is common, CKD is also very common. And sometimes we need to remove these tumors, cyst, but what we used to do was small tumor, ultrasound, CT scan, complete kidney out, radical cystectomy was used. But we felt that this is kind of overdue. In many cases, the kidneys can be preserved, because in future, these patients are coming young now. In future, they may have a chance of diabetes and CKD in future. So we want to preserve as much kidney as possible and in a minimally invasive way. So now we are doing partial nephrectomy and by laparoscopic or robotics techniques. And we have special sutures, special instruments for those. Or just small video and then end the session.
Thank you, Dr. Kumar, for nice elucidation of male LUTs. Male LUTs are indeed very complex subject and should be treated very diligently to improve the quality of life of the patient. I would like to emphasize 2 points here. One is male LUTs are the most common presenting feature of prostate cancer. So every patient above 55 presented to you with the LUTs should get a PSA screen. The PSA is raised, then he should get appropriate referrals so that prostate cancer if detected early can be cured and that save lives. So that is an important thing to remember. The second is diabetes itself can lead to LUTs. So every patient presenting to you should get a diabetic screen, LUTs patients. That's it. Thank you, Kumar. Dr. Kumar again.
Thank you, Speaker sir. Thank you, Chairperson sir. Any questions?
Thank you very much. I was worried that I have spilled over my time, but you have kept in time, so it will be better for organization. Now, the thing is, in our outdoor, we have urology side by side. We are doing neurology. Although patient is going mistakenly, urology patient coming to neurology, and mistakenly neurology patient is going to, they are going very easy way. We have a small distance of a few centimeters, but psychology in the outdoor, we have long distance between this urologist and neurologist, psychologically. So I will be assembled in my association to ask these questions, because forever I may be stigmatized. Now my question is maybe silly. The thing is, what is the role of masturbation in reducing or increasing the chance of BPH in male, and what is the role of masturbation in women for LUTs? So if you give a comment about that.
Questions I gathered from your very interesting one actually. I never thought of that someone will ask me these questions here. So I deal with mostly cancers, and so there are enough evidence to say that persons who are having more sexual activities, can be ejaculations, more number of ejaculations, are having less risk of prostate cancer. EPS regarding any, Rajesh, any?
There are many evidences now that point to the fact that repeated release of the seminal fluid will reduce the risk of prostate cancer. Be it by masturbation or by actual intercourse, that may vary, but repeated release of the seminal fluid will lead to, repeated ejaculations will lead to reduce the risk of prostate cancer.
So these sexual life things are not very commonly discussed in meetings, or maybe the patient also feels not very confident about asking these questions in meeting. But once you start asking these questions, you are surprised, oh, it's that common actually. Like we hardly used to bother about the sexual life of the patients of the radical cystectomy and radical prostate. Then we came with the idea of organ preserving, nerve sparing, radical prostate and all those, because we felt that 60 is not the end of sexual life, and patients in the 60s and 70s are desiring or want sexual life. So thanks for raising the next question.
And the answer of the female?
Females, yes. See, in diabetes, yeah, as very small 2 lines about the sexual dysfunction in diabetes patients. And so, sexual dysfunctions are common in both males and females as well. They have the pain, they have the decrease in the libido, and this because of diabetes. So, once you are having a patient in diabetes, in your opinion, just please ask me these questions. You will get a lot of questions and insights from them. There are not a lot of things which are available in the market to cure or treat those problems.
My question is another question. Role of masturbation in female?
Frankly speaking, sir, I have no idea what no idea. Arise, any idea? Role of masturbation in females?
Regarding
Thank you, sir.
Thank you.
Thank you, Speaker sir. Thank you, Chairperson sir. A small moment, a token of appreciation from Howrah Diabetes Study Society, and it's Ma Durga on the eve of Mahalaya. So, thank you. Thank you, Cipla, for sponsoring this particular